Efendim merhabalar, hepiniz hoş geldiniz.
Hello all, welcome. Let's start timely so that we finish timely on time. Together with Ali Evren, we are going to talk about the treatment approaches in ADHD treatment and the use of Guanfacine, our clinical experience, and the researches. Our main objective here is to have a look at the prevalence and treatment, I mean ADHD cases, not only limited to childhood psychiatry, but it has a protective side for the adult psychiatry. So we can talk about treatment options deeply. I will make an opening speech and then followed by Ali Evren, and we want to have some time for Q&A session because in such drug groups where our experience is limited, it's valuable to hear your experience and your contribution, and your questions will contribute to the better understanding of the situation. We would like to thank you for your participation once again. ADHD is one of the most frequent conditions that we face in child psychiatry, and in terms of treatment, if treatment is started earlier, we get better or good results. In the Turkish epidemiologic work, its prevalence is as high as amounting to call it as a public health problem. The historical background of the problem is that due to definition, child psychiatry, it's more on the agenda by the child psychiatry. However, in 1902, for the first time, there was an article published, and in 1890s, it was recognized by a few articles, but in 1902, British pediatrist Sitter's definition of the disease is the same as the disease in the classification system that is comprising of three main classification factors. It's a brain disease, it's a prefrontal cortex disease. In 1902, it was defined as a problem which is defined as incapability of regulating moral values. So academic performance is lower in a group of children, and the average age group, they are more active, and the same group, the moral values, ethical values, and they're having difficulty in learning ethical values. So today, ADHD, these are the three pillars which defines attention deficit, hyperactivity disorder, and impulsivity. Although this was introduced into DSM-5, it's a disease that's there for 100 years. What has changed? We know that ADHD is not seen alone. the child psychiatry, one of the biggest differences is that neurodevelopmental disorders, the symptoms may be mixed from for instance, a case at the age of 2.5 years, it can be delayed speech or not receiving instructions, or it may be a sign of problems or not having eye contact. These developmental problems correspond to which disease is not an easy process. That is why, while we are approaching to this, especially in the early stages, in differential diagnosis, we focus it in a more detailed manner, and we need to follow the process closely. As child psychiatrists, in early stage cases who came to us at an early stage, psychotraining and family counseling is significantly affecting the life of the baby, of the family. Parents who come to you, if they bring their child to you, there must be a reason. It's not for a simple control. Whatever they suspect, although we do not understand what it is, you need to follow them up. Don't tell them come after 6 months. Instead, tell them come after 2 months, 3 months, so that you can see how it has progressed in a bad way or in a good way, so that you can adjust your treatment. In neurodevelopmental problems, early intervention has positive impacts both at early and long run. ADHD, well, when we have a look at the symptoms and signs, its identification using scales, getting information from the teacher, it's not a difficult process, but we know that ADHD is comorbid with many different psychiatric disorders, and these comorbidities may cause problems for us. On the other hand, we as clinicians, when we have a look at the situation, we focus on a main concept. Even if there is a disease there, what about the loss of ability? What about the impairment of quality of life? These are determinants. So this is the main factor. Loss of ability and impairment of quality of life are important. Here in ADHD, one of the biggest problems disrupting quality of life is irritability. In children, whether it's comorbid or a version of ADHD, opposition defiant syndrome shows ADHD very clearly. So you cannot skip it. A child with irritability, if you try to correct their courses, and if the priority, you say that priority should be on the academic success, it doesn't mean that you treat them, because the child's relation with the teacher, with the friends, with the family, the most disruptive factor is they get angry easily. They cannot regulate anger. They cannot control anger. And it manifests itself in the form of violence, manifests itself in the form of behavioral disorder, and it cannot be recovered through tolerance. That is why teachers and parents complain a lot about anger management, or due to hyperactivity, the child might be damaging, harming themselves or those around themselves. So we, first off, us and then parents and then teachers should explain what our target in treatment is. When you correct irritability and when you think that the patient is successful, their teacher may complain that no, it's not the case, they are still not writing or doing anything. However, if you explain the teacher that not writing anything is a problem, but this is not the main problem, it's at the bottom of the list of problems, so it means that the results are not good. So, as a recovery criteria, yes, there is the information derived from the child, but especially in small children, feedback that we get from the parents and the feedback from the teachers are important. So this feedback, in order for it to be healthy, first off, the most important symptom, valuable symptom, disruptive symptom, what it is, should be understood, and how we should address to it should be taken into consideration at first, and we need to explain it to the parents, to the teachers, otherwise it's like being in a vicious cycle. How can we make the diagnosis? It's also complicated, and these complications may not be a big problem because we have certain criteria to make diagnosis. We have some observations. However, for our young colleagues, let me emphasize one thing once again. In psychiatry and in child psychiatry, there are two diagnostic tools. Now, I do not know the number, what the number will be in the future, but right now, there is no other tool that is helping us to make diagnosis. First of all, good anamnesis. You need to have a good anamnesis. So 70 or 80% of it helps us to make the diagnosis. If you take the history, good, if you ask correct questions, it's easier to make diagnosis. And the second factor is observation. You need to observe. And doing it in the very same session, especially for the physicians working, our residents working at university hospitals, public hospitals, it's not easy, we know that. However, except for urgency, we do not need to finish everything in the first session or make diagnosis in the first session. You need to use the tools for gathering information. You need to invite them for interviews again. And after that, something has become clearer on your mind, then you can make your diagnosis. Apart from that, the tests, the scales, measures, well, parents come to you with these tests recently, because these are like attention tests or certain tests. So parents who are presenting you with scales and measures are guiding you. So you need to put them aside, and you need to clearly ask that, starting from the infancy, you need to get the anamnesis that will cover areas that you have not focused on, because we need to know other comorbidities, and anamnesis should be more widespread. And observation, clinical observation, be it 5 minutes or 45 minutes. Only one observation misguides you in child psychiatry. For instance, the most hyperactive child may sit beside you silently for 45 minutes. However, after the third session, he will just climb on to your head. So observation or quality of observation cannot be limited to one single session. The child, where they have reached, or the position, should all be taken into consideration within the scope of observation. And Professor Vatet stated that when he was a resident, they were sent to schools. We wish that we could go to schools. However, if this is not possible, it would be best to make observations at schools. Observing a child for 5 minutes during break time is more valuable than evaluating it in the office setting, because not every child shows the same signs. This is not about the depth of psychopathology. Personality traits. Apart from psychopathology, there are different factors that hide it. So if there is an anxiety, if the child is anxious, they may hide it, and you believe that this is a very well-behaved child, a non-impulsive child. So, first off, we need to be patient if there is no urgency, if they are not damaging, harming others, or not on the verge of sacked from the school. And the anamnesis should be taken in an in-depth manner to cover all other psychopathologies. I'm not going to dwell upon them. As you know, ADHD is a brain disease. Definition of the disease, maybe in the future it will be changed to a prefrontal cortex disease. We are talking about the disorders in the executive functions. However, there is a genetic transmission, so there is a risky group. But when it comes to the percentage, Gül, was it 13% who requires drugs? It can be up to 16 or 19%. So there is no individual who doesn't have ADHD in their family. That's why we need to approach to it like this. In terms of treatment, ADHD treatment is not an easy one. Although we have strong medications, there are certain caveats. First off, treatment of the disease with a medication, you need to convince, and you need to have continued drug use. And when families ask questions, when will you stop the therapy, you need to find an answer. You cannot find an answer. However, the parents are waiting for answers from you. You need to explain it to the parents. So there is a problematic part that time to time, if we do not provide good training to the parents, it means that treatment cannot be completed. Why? Treatment lasts longer, or the family stops drug believing that the patient has recovered, and their neighbor may ask, what drug are you using on your child? Are you going to poison your child's brain? And then they stop using the drug. That's the problem. I do not know, maybe it's valid for adult psychiatrists, but for child psychiatrists, their knowledge is below normal. And there is an aptitude for stopping treatment. This is due to lack of knowledge, and they are violating our field. And most importantly, there is a group which is drug resistant, and due to side effects, there's a significant group where we cannot use drugs, and there's a group where there's a need for drug combination, and while doing so you need to persuade parents, which is not an easy thing. So treatment difficulties is one of our problems, medical problems. We want, as child psychiatrists, that alternative drugs will be more frequent or will be expanded in the treatment of ADHD, so that we can have, so that we can be strong. Because let me emphasize once again that in the guidelines it says that use this one or use that one, and even in these drugs there might be significant side effects or non-effectiveness of the drug. So my final words is that especially when there is irritability and anger seizures, be it comorbid or not, we have a huge problem in ADHD patients. This is very difficult for us. You may ensure that you may reduce hyperactivity. However, if you do not prevent irritability, then that child will not be considered as recovered by us or by their parents, because irritability is something that deteriorates quality of life. Thank you very much. Now I'm turning to ALİ Evren. Distinguished participants, thank you for your participation. I'd like to thank the organizers, and I'd like to thank ALİ RAİF Pharmaceutical Company. Together with Professor Mücahit, it's an honor for me to make this presentation. He is one of the most prominent figures. So I'm going to talk about the update in treatment of ADHD by presenting you with cases, etiology, co-definitions, and neurobiologic basis, and the role of non-stimulants. ADHD, as explained by Professor Mücahit, I can add that, as in the case of other neurodevelopmental problems, there is the signs, symptoms are distributing normally within the society. If they exceed a threshold, then they disrupt normal functions or functioning. Prevalence is 5, but in our country it's like 13-14% more dominant in boys, but attention deficit type is more frequent in girls. Well, there are the fines that are not in line with developmental process, but this is only tip of the iceberg, because there are many other problems and symptoms. And in adults, ADHD mixed type is frequent. In adolescence, it's like 60%, and in adulthood, it's like 40%. And in the adulthood, functionality may be impaired, although the signs are below the threshold. Cases show difficult traits since their infancy: irritability, emotion regulation problems, and interpersonal relations are problematic in these cases. Symptoms vary by age, and motor movement becomes less distinctive. However, disorganization and ADHD, with development, they may change from adolescence to adulthood. There are studies involving Turkey, so they may stop therapy and they have difficulty in continuing therapy. Low IQ, comorbidities, psychopathology, and additional problems, or lack or insufficient treatment. This diagnosis or functionality problem may continue. In 2021, there is a meta-analysis. There is a 4.3 times of increased mortality in adulthood. So treatment is important in terms of preventing mortality and morbidity. Attention deficit hyperactivity disorder, there are some environmental factors. However, these are there in interaction with other factors, and genetic works underline the role of none of them is sufficient alone. Well, adult psychiatry, neurosis, psychosis, abuse, etc. However, adolescent and child psychiatrists make an evaluation differently, so the limits of syndromes are not clear. In adolescents, there may be comorbid psychopathologies, alcohol and substance abuse disorders, and mood disorders. When they are added to the table, it is a risky period. ADHD cases, sleep disorders, autism spectrum disorders are there before ADHD, and simultaneously learning disorders or syncope can be there, and after that tic disorders, depression, anxiety disorders, and other disorders may come to the fore. Attention and impulse control, dopamine and noradrenaline should be at an optimum level at prefrontal cortex, and in parietal lobe and cerebellum, and slip of attention are there. D1 dopamine receptors are low. When we stimulate them, we reduce the voice that disrupts signal, and if noradrenaline disruption is there, if it is overly excessive, then we can say that there is an impaired function of dopamine adrenaline receptors. Optimum alpha 2A, optimum D1A stimulus are there. Sometimes dopaminergic or excessive discharge, the response based on stimulants, or you may see more robotic behavior. As mentioned by Professor Mücahit, medication, drug therapy is the main therapy. However, there is a need for a multifaceted approach. So imaging, neuroanatomic works, neurologic and functional changes may be reduced by medication therapy. For treatment algorithms, nice algorithm in cases below 5 years of age, cognitive behavioral therapy and parent therapy. If this is not sufficient, then medication. Those above the age of 5 years, drug therapy is added. And although you administer drug therapy, then cognitive behavioral therapy can be added to the table. So methylphenidate, dexamfetamine, atolmexetin ve guanfacine are there according to the NICE algorithm.
When we look at the Canadian algorithm, we have the long-acting psychostimulants for the first-line therapy, and we know that if there is any side effects, specific side effects, low response or excess problems to the drugs, then we can shift to the second line, and in the second line we can use short or medium-acting drugs. And for the German algorithms, we see that there are symptoms at moderate level. If this is so, then we give medical therapy. And if there is non-response or any other contraindication, guanfacine is indicated, and we know that it has some contraindications and side effects. So based on this evaluation, you can prescribe it lonely or as a monotherapy. Spanish algorithms. First, the CBT and parent training are recommended, and then comes the medical treatment, and they focus on the drugs and their relations with the symptoms one by one. And Guanfacine can reduce irritability or objection, it says. And as I have mentioned, most algorithms recommend stimulants first and then non-stimulants in the second phase. For the ADHD therapy, 2 neurotransmitters and 4 treatment approaches. We have noradrenaline and noradrenaline and dopamine, and we can initiate a psychostimulant effect, and also we can use other antagonism mechanisms. So if we are to summarize these algorithms, if there is no comorbid anxiety or if there is mild anxiety, stimulants are recommended. However, if these are the cases, atomoxetine can be given for objection, and also guanfacine can be used for this purpose as well. For sleep disorders or tics and aggression or post-traumatic stress disorder, guanfacine can be effective again. Non-stimulant drugs, although they have a slow impact, we know that they have better results in terms of the other side effects. And in 2020, there was a review conducted, and for all age groups and comorbidities, they have specific recommendations. And here you can see them in summary, and we have mentioned about them within the algorithms. So, non-stimulants, we have atomoxetine. It is a selective norepinephrine reuptake inhibitor, and it increases both noradrenaline and dopamine levels, and it doesn't have an abuse risk. And after 4 to 6 weeks of use, we see the effect in a better way, and active metabolites can contribute to this impact. And also in cases of behavioral problems or objection problems, we can increase the dose. The recommended dose is 100 milligram. And CYP2D6 polymorphisms and similar enzymes can also be effective, and it is effective for all aspects of the ADHD. And if there is any comorbidity such as drug abuse, anxiety, or tic disorders, it can be used in the morning or late in the night. And we know that it has less side effects in terms of sleep duration and arrhythmia. Guanfacine, we have 1, 2, 3, 4 milligram doses with guanfacine, and you need to swallow it. You should not bite it or chew it. And FDA recommendation is starting it with 1 milligram per day, and you can increase it every day by 1 milligram, so you can reach the highest doses at 7 milligram in 1 week, and the clinical impact can be seen in 3 to 7 weeks. And in combined therapy, while you discontinue the drug, you should reduce the dose by 1 milligram every 3 days. And guanfacine was first approved for hypertension in 1986, but when we look at the catecholamine discharge and its functional effects, it can be used in other areas. FDA actually approved guanfacine for the ADHD treatment in 2009 for 6 to 17 years of children as a monotherapy, and it was also approved in Canada in 2015. When we look at the preclinical trials, we can have some ideas about where and how we can use it. It reduces amygdala plasticity, it reduces the release of norepinephrines, and it reduces microglia activation, and it suppresses neuroinflammation. And there are some preclinical studies about the neuroinflammation process, and voltage-dependent calcium channels and MAP kinase are blocked. This is why it reduces glutamate release, and also we see that it reduces pain with the blockage of the voltage-dependent calcium channels, and it suppresses sodium flow as well, and we know that it reduces the stress side effects on the working memory. For 6 to 12 years of age, it is 1 to 4 milligrams recommended, and for 13 to 17 years of age, it's 1 to 7 milligrams per day. And sometimes we see short-acting clonidine is given to some children, and when they try to shift to guanfacine, you may need to increase the dose by 30%. And alpha-2A receptor affinity is much higher with guanfacine. Therefore, in terms of sedation, it is much safer. And 6 hours later, it reaches the maximum concentration. Half-life is 18 hours, and the stable situation can be achieved 4 to 5 days. Pharmacokinetic is linear. Therefore, valproate and fluoxetine and other agents can be combined with this drug, but you should do it with great care. And the side effects are mainly mild or moderate level based on the dose, and randomized controlled trials and meta-analysis show us that sleep tendencies may appear with guanfacine treatment mostly. And the trials showed that the treatment went on for 4 months approximately, and it shows us that the combined therapy can be more effective for ADHD treatment with guanfacine, but again, side effects may increase. And when we look at ADHD issues, there are some trials that show that you can choose guanfacine for those patients, and 12 trials and 2,653 cases were analyzed in a meta-analysis on ADHD, and the efficacy was found to increase after 10th week, and again, a tendency to sleep, headache, and also feeling tired may be among the side effects. There are some other trials about other age groups and other comorbidities, and these are based on preclinical settings. When we look at the trials in other countries, sometimes people may crave, and this can be used to manage craving, and also mental retardation or ADHD plus autism can be comorbidities together, so it has an advantage in this respect. And we know that its effectiveness is maybe a little bit higher when compared to atomoxetine, and at the beginning, when you give the treatment based on the dose, there could be some changes in systolic and diastolic blood pressure, and also some pulse issues and other side effects as well. So in clinical practice, how can we use it? The first case, 14-year age boy, adolescent, and he attacked his family, and at 11 years of age he was diagnosed with ADHD and autism spectrum disorder, and AMPH IR 30 milligrams and APZ 10 milligram per day was given, and his parents prevented him from playing the computer games, so he had a tantrum, and he started hitting the family and throwing the materials away, and he actually benefited from the treatment. Another patient, 10 years old, a boy, and he was diagnosed with ADHD, autism spectrum disorder, and also Tourette syndrome, and risperidone was started. However, he couldn't tolerate the therapy because of the headache and also urination problems and concerns, and at the age of 7 he was given ATX 30 milligram, and again the drug was changed later on. However, it didn't work, so guanfacine was given, and it was gradually increased, and the sedation effect was achieved with this drug. 10-year-old girl, nocturnal urination and attention problems, activity, impulsivity, and alarm therapy and other behavioral management were recommended. And at 7, he was diagnosed with ADHD, and Guanfacine was recommended, and the sleep problems was reduced, and enuresis problem went down to once a week, but still goes on. Thank you very much for your attention. Thank you. Can you open case 2 from the last slides of the presentation, please? This one, yes. Dear colleagues, we have some time. I would like to focus on a case, this case especially, and comment on it, if you allow me. This is actually Bermuda's Triangle. If you have such a case, you should keep thinking about it, think again and think again. Because just as I have mentioned previously, sometimes you don't receive information from the family about the history of the child, and you may miss OCD and also tics because the parents never tell you about them. They never tell you about the obsessive signs. For instance, the child stays in the toilet for 30 minutes and he keeps closing the doors, or he keeps checking on the lights. And why do you see this child? Because the child is not successful at school. I mean, academic purposes, they come and see you. And they sometimes tell you that our child puts on and takes off his shoes 20 times when they are trying to go to school. And when you meet the child, you'll see the tics, you will understand them. They try to hide some of them, the children maybe, but in the next session you will understand it. And when you ask the parents if there is a kind of tic, and they say that yes, sometimes there are some tics or repeated movements we see, and we see that the child has Tourette syndrome and the family missed it. This is what we see very frequently, and parents, unfortunately, come and see us complaining about ADHD. Of course, when they go to other clinics or other doctors, we understand the symptoms there. But what should we do here? As a physician, in 15 minutes, we may see ADHD symptoms. You send Connors to the teacher, and Connors was also filled by the parents, and you give methylphenidate, and they said that our child has strange tics, but actually it didn't appear now. They were already there, or they may have stopped the drug and visited another doctor from clinic A to a clinic B. And for OCD, for instance, you may not have realized it, and you may have given stimulants to the child, and during the stimulant therapy, anxiety may increase, which already existed, and OCD symptoms may increase at that point. And if they didn't realize it before, they may come and complain you and saying that you actually made him worse to us. And when we ask about the tics or reflexes, involuntary movements, we understand that actually the child has OCD for a couple of years, and ADHD and behavioral problems. For instance, when we look at the behavioral problems, we mostly think that it is about the antisocial child, because when I use a scale, I do not let the child to put these answers to this part about the behavioral issues. I mean, you should not ask in a normal ADHD case if you had been engaged in robbery. So you should be actually impairing your relationship. And I tell them that this part is not about you. And when there is a behavioral problem and if it also involves a physical violence, this is the most difficult part, because this is about irritability and he can be triggered very easily. For instance, Ahmet looked at me, or he hit me while I was going down the stairs, and this is why I threw my bag at him, and he swore at me, and this is why I, for instance, punched him. So irritability can be the case, and this is actually the summary of what I'm trying to tell you today. In such cases, we should have alternatives and create some alternatives. While developing such alternatives, we have classical drugs for the ADHD therapy, and we use them. And if we add another drug to those classical ones, this will be significant, because as a clinician, yes, there are indications, we know about them, but I have lots of experience as well. So the physicians have to develop some solutions if they are having difficulties or complex cases. And thanks to the pharmaceutical industry, we have a new agent, a new solution sometimes. And it is said that this is an agent that is used around the world, and now we have it available in Turkey. And there may be questions about it, but in terms of using antipsychotics, if you are afraid of using them, of course, this is another type of discussion, because it is a good alternative for a group of patients, especially for combined therapies. So this applies to what our professor said. And when you add some additional protocols to your treatment, you may have good results in terms of irritability. And we should always keep in mind that side effects is the most important reason why people discontinue their treatment. And people, especially adults, are more patient about the continuation of the therapy, but for their children, they are not as patient as for themselves. And for instance, there is appetite loss, and this may be the reason why they stop using the drug. And the parents say that he doesn't eat, so I don't like it, so I don't use this drug, no matter how much benefit it will provide. So alternatives, this is important for this reason. And I believe that there will be questions or comments or contributions from those who may have used it. We have 10 to 12 minutes in the last part of the session, and we can take your questions and comments and contributions about that. Thank you so much. I would like to talk about something that is out of topic. I don't know if you know it well or not, but Mücahit is a professor who is working for the future of Turkey, and he is also the president of the Green Crescent Society, and he has been involved lots of projects, and he has made significant contributions to the Green Crescent Society centers, and people are always talking about the fact that there is a huge level of drug abuse in this country. There is also tobacco addiction at a very high level, and on the cigarette packages we know that it is written and says that it kills you, but most people smoke them. And I would like to appreciate your efforts in this field, and I would like to extend my respects to you, and your efforts should be told to all the psychiatrists about these efforts because it is a very important point that you are making such efforts and our colleagues should know about them. In the afternoon session, we have a session about the addiction. I would like to thank you very much for your nice words. Why are we trying to treat these children so that they should not become addicts or should not become criminals? And let me share memory with you. In 1992 or 1993, I was a resident in Chapa, and we didn't have many drugs back then. And Menderetes was the Melderetes, actually, because it had some toxic effect, and this is why we don't have it now. And it has a sedative effect, and for aggressive children it was good, and we were just prescribing a couple of drops for children. And we have Atarax on one hand and toys on the other hand for such children. This was how we described it. And a mother came to me from Ankara, and it was in the evening at 5 o'clock, and she asked me to see her child. And Chapa Child Psychiatry was a place that was very busy, and I could only leave there at 8 p.m. in the evening. And if you love your profession, you can be successful. I was at the door. I was trying to leave at 5 o'clock then, and she asked me if I could examine her child, and I said yes. And the child is around 7 or 8 years of age, and there is the Millet Street. You can see the street from the window, and she said that I will not be sad if this child was hit by a car while crossing this street. And I asked why, what happened, and he was sent from school and lots of behavioral problems and ADHD, so many problems. And I tried to explain him and her, sorry, this is a disease, we can solve it, and we have friends in Ankara and you can go visit them. And she came to me, we managed the treatment, and later on, years later, she wrote me a letter. And I was going, she told me that I told you that if this child was hit by a car, I would not be sad while crossing the street. This is what I told you, but that child is now a doctor. She wrote this in her letter. So this is a very sentimental thing, and child psychiatry is very important in this respect, and medical treatments can be given, and all these treatments can actually save a child's life. Thank you very much for your nice words, by the way, once again. Distinguished professors, I would like to thank you for your presentations and your experiences and for sharing them with us. My question is about Guanfacine. When we use it in monotherapy or combined therapy, do we have anything about the cardiac parameters? Do you check the cardiac parameters, or should we be checking them when using Guanfacine? Thank you very much for this question, Fethiye. This is a very important point you touched upon. When we look at the product information or the launching information about the drugs, the cardiovascular risk factors should be evaluated, they recommend, and ECG should be used to follow the patients. And although it is recommended that you should increase the dose by 1 milligram per week, we wait a little bit longer to gradually increase the dose, such as 2 weeks sometimes or 3 weeks sometimes. This is why we didn't see any cardiac side effects. But as I told you at the beginning of the treatment. Systolic and diastolic blood pressure changes may occur, and also pulse increases may occur, as mentioned by the product info, but we do not have significant side effects reported in Turkey as well, but we should still be careful and take necessary measures. Distinguished colleagues, we need to follow the literature, because for other drugs or for this drug, while taking the history of the patient, we also ask the parents if they have any cardiac pathology, or if the child has a congenital cardiac pathology. They do not tell you, and you should ask this. They do not tell this before you ask them. And for instance, sometimes they say that yes, he had an aortic surgery. We should have a good medical history, but you should not send or refer everyone to cardiologists. This is actually wasting resources and time. And if I was referred to a cardiologist, I would not use that drug. If there are risk factors, and of course, you could ask for consultation from cardiology. ECG is something I do not understand. So we cannot ask for consultation for something we don't understand, like ECG, because I don't understand ECG. And alpha-2 adrenergic receptor drugs was some of the agents that I had experience with, but I saw only mild changes, and if it was a very good blood pressure drug, it would be used for that purpose, but it's not used for this purpose. They do not drop down blood pressure, but we should check for blood pressure levels. And for methylphenidate, this is the same. Arrhythmia or heart attack, I mean, if there are such symptoms, stop the drug and refer this child to cardiologist, and ask for a written document from the cardiologist. I mean, ask this to cardiologists and tell them in that document that you will use this drug for this patient, and is it okay for such a child, because it has some cardiac effects, and based on his response, you can prescribe the drug. Thank you very much for this presentation. Guanfacine used for adult patients. I don't have any experience. Actually, I used it in the past for a long while. I don't see adults, but for adolescents, yes, we use it, but I haven't seen adults for a while. We don't have data about them. Thank you for this question. In Turkey and in the world, it is used as an augmentation therapy or monotherapy for the patients between 6 and 12 years of age. And in Japan, it was approved for the adults. However, this does not apply to our situation. Thank you. One more question. Thank you very much for those presentations. My question is that in combined therapy, if we add guanfacine as in a combined therapy, should we adjust the doses of other drugs, other agents, methylphenidate or atomoxetine? Thank you very much for this question. Although we know that they are not interacting with each other much, so we can reduce the dose to be on the safe side. Our slogan, start low, go slow, to protect the patient from the side effects. And with this motto, we haven't seen much side effects. However, combined therapy is always characterized with an increase in side effects. This applies for all drugs. I mean, I have an objection here because we know that we should use the drugs, prescribe them based on milligram per kilogram, and if there is any side effect, then you may see some patients or families who are against all the psychiatric drugs. So it is better to start with low doses. Shahin, you told a couple of words yesterday, and there was a presentation about Guanfacine by our young colleagues, and maybe I can pass the floor to him so that he can comment on that. Thank you. In our ADHD treatments, it's an alternative, and alternatives are always good. By 20 to 25%, we see resistance, and the alternative can actually fix this resistance, I believe. And rather than classical comorbidities, we have some complex cases, very hard cases: ADHD plus schizophrenia, bipolar plus ADHD. So in such cases, we should have remission for schizophrenia, we should control bipolar, and then we can treat ADHD. But until that time, ADHD causes some functional problems, functional losses, and it goes on during that period. For bipolar, for instance, we try to control bipolar mania and the attention deficit, and also ADHD's attention deficit. How can we distinguish them? So Guanfacine is a good agent in this respect for our country, because for very hard cases, difficult cases, it's an alternative. And we have schizophrenia and ADHD, or bipolar plus ADHD. It helps us actually prevent that loss of time we face. Thank you. Thank you very much. We are just on time. It is now 12 o'clock, sharp 12. Thank you very much for your participation. And ALİ RAİF, I would like to thank them for their support as well.